So good morning, everybody. My name is Nora Kennedy. I'm the Vice President for Research. And I'm delighted to be here this morning. Unfortunately, I can only stay for a little bit, but I genuinely am just so excited about this session. And just to say a few words about Research Week to contextualise this session a little bit for you all. Research Week is a really busy week for the University of Limerick. And it's our opportunity to do a number of things, to showcase the wonderful work and research and the excellent research that happens at the University of Limerick, and to show that across the organisation. And I think this year is a real, the first time I've seen such an amount of events are in parallel. There's such a range of things happening. And a really common feature is interdisciplinarity. And this morning you're going to see a huge amount of that here and showcased today. I would like to congratulate Katie and Rose and colleagues and Sarah and Aoife for their leadership around ageing research at the University of Limerick. The HRI, in which the Ageing Research Centre is situated, I think has done a fantastic job this week as well in showcasing the range of work that's happening. So the opportunity is to showcase what's happening, but also to allow new conversations and opportunities to emerge. So events like this, time out of busy schedules to reflect, to see what's happening, to hear a little more, and to engage and hopefully spark new ideas. So it is a fantastic opportunity. I won't take much more time because you've got a very exciting agenda ahead of you all. Congratulations to everybody and best of luck. This is a really important area of research for the University of Limerick, and we have wonderful research captured within our ageing umbrella. So congratulations to you, and enjoy your morning. You're going to have a great morning. Thank you all.
Norlie, thanks for the lovely introduction. Norlie and I started work together on the same day. She is the Vice President Research, and I'm still doing some of the same work I did back then.
No, you're not, Kate. You're very important way, I would say. You're very understated about it.
Stop. So good morning, everyone. Good to see you all, and you're very welcome to this session. This Research Week has been a fabulous event so far. Lots of opportunities to celebrate, as Norlie said, and showcase what's going on in the university. This morning, the Ageing Research Centre are delighted to have 3 colleagues presenting their work. I'll introduce them in a moment. But just to say a couple of short bits about the Ageing Research Centre. We've had a fabulous year, 2023 to 2024, loads of success. In the last 12 months, in the centre, we've published over 62 papers that are indexed in PubMed. We've graduated or had 7 students complete their PhD vivas. And this is just testament to all of the good work that's going on in this interdisciplinary centre. First up this morning, we have Dr. Aoife Leahy, who's a consultant geriatrician and PhD candidate, and she's going to present on the SOLAR trial. So I'll just pop up Aoife's slides.
Good morning, everyone. It's such an honour to be here and to be involved in the ARC. So it's really important, I suppose, to highlight what we do as part of the research that is done through the ARC. So I suppose the work I've done is a collaboration between a number of different areas. So the UL Hospital Group, UL, and the HRI and the Ageing Research Centre. So I suppose what I'm presenting on is the work that I've done as part of my PhD that I'm working on at the moment. So I suppose the hypothesis of the work that I've done is, as we all know, there's rising numbers of older adults presenting to acute hospitals. And how do we manage this? And as I'll show through my presentation, the numbers of older adults presenting is going to increase as we go forward. And how do we manage that in the current system? Frailty screening tools are increasingly used in the emergency department for predicting those at risk of adverse outcomes. And we're going to look at how we've looked at that and how we can predict those who are more likely to have adverse events. And the last part of my PhD work was using screening tools to risk stratify older adults in the emergency department for Comprehensive Geriatric Assessment. If we look at the projected population aged over 65 over the next 20 years, there's going to be a dramatic rise in older adults presenting to acute services. And I suppose we need to look now at our systems and how we're going to manage that going forward. It's predicted there's going to be 300,000 people in Ireland over the age of 85 by 2051. And these are patients who have frailty, who have complex needs that are going to need assessment and management in our current system. So I suppose looking at the older person services model nationally through this Launch Care model, there's a great push to shift to the left. And what that means is trying to manage patients as much as possible in their own community, as much as possible in community ambulatory hubs. And if we need to, then frailty at the front door services, comprehensive geriatric assessment and specialist geriatric wards, but to try and minimise the amount of time in the acute hospital part of the system. So I suppose, what is frailty? So frailty is defined as a clinically recognisable state of increased vulnerability resulting from ageing-associated decline in reserve and function across multiple physiological systems, such that the ability to cope with everyday or acute stressors is compromised. And I think this schematic is a really good way of looking at it by Clegg et al. So what we have is, when you're robust, you can deal with a stressor well, so that you go back to your level of ability after your acute stressor. But with increasing levels of frailty, your ability to return to your independent state afterwards decreases. And with severe frailty, even with a very minor stressor like constipation, infections, new medications, people can go from a state of independence to a state of dependence. And I suppose this is the area that we're looking at. For most of the research, age is not a good determinant of how people deal with stressors, and frailty is another way of looking at this. Looking at the research that has been done in frailty, there's two different models. So the Fried model is the phenotypic model, looking at 5 different areas of weight loss, weakness, exhaustion, slowness, and low physical activity level. And then the deficit model, which is Rockwood's Frailty Index. And this looks at the number of deficits that you have out of a total number, and that number gives you a greater indication of how frail you are. And they're the kind of 2 areas that we look at. But these are difficult to do in routine clinical practice. So I suppose the areas that we've looked at are looking at frailty screening tools as a means of doing this. I suppose all this work is underpinned by the MRC framework. And what we are looking at is the feasibility of these interventions, how we identify an intervention, how we evaluate it, how we implement it. And I suppose the core elements of considering the context, like doing these things in the emergency department, is very different to doing it in a primary care centre. So that obviously determines how applicable some of our interventions are. And I suppose, as part of my thesis, the areas that we looked at, we're looking at the different roles that context plays, and we did this through different systematic reviews in the cohort study, which we'll talk about now. So the first area that we looked at was the SOED study, and this is a cohort study of 419 older adults. And what it was patients who presented to the ED in the University Teaching Hospital, and we looked at 4 different screening tools: the ISAR, the Prisma-7, the Clinical Frailty Scale, and the Inter-Ray ED. And at the index visit, they had these screening tools applied, and then we looked at their outcomes at 30 days and 6 months. Overall, these patients, their mean age was 76.9. Now, I'm a consultant geriatrician working in ICPOP services. I only see people over the age of 75, so this was a younger cohort than what I'm seeing at the moment. But even with that, 50% of these patients arrived to the hospital by ambulance, and only a third of them had seen their GP beforehand. But if we look at the Barthel score, which I'll bet has a ceiling effect, the Barthel index for these patients was 18, so that's a relatively independent cohort of patients. But despite that, 1 in 20 of them had died at 30 days, 1 in 5 of them had represented to the ED, and nearly 50% had self-reported functional decline at 30 days, and over 50% at 6 months. So despite this being a relatively independent cohort of patients, these patients still had adverse outcomes. And we look across, this is hard to read, but across the screening tools, this was very similar. So I suppose, when we looked at the overall prevalence of frailty of patients screening positive for frailty in this group, it ranged from 57 to 70%, depending on the screening tool used. So that means that in our emergency department today, nearly 70% of patients in this study were screening positive for frailty. So this is a high prevalence, and I suppose it's an area that we're going to have to look at, because these patients are getting adverse effects. So I suppose when we're looking at the system overall, if you don't change the system, you change nothing. So we know this is happening, and I suppose the role of the SOLAR trial was to see what we could do about it. So what the SOLAR trial was the impact of frailty screening of older adults with multidisciplinary assessment of those at risk during emergency hospital attendance on the quality and safety care, and this was a randomised control trial. The inclusion criteria are patients over the age of 75 with a Manchester triage category of 2 to 5. So patients who needed resuscitation and things like that were excluded. Patients presenting with medical complaints and those who screened positive for frailty on the ISR. We excluded patients outside of the hours of 8 to 5, Monday to Thursday, just because of the way the team worked, and those who were acutely unwell or had non-medical complaints. This is the ISR screening tool, and if you scored a 2 or above, you were suitable to be included in the study. And this is a very easy tool that can be brought in emergency departments. Now, there's different frailty screening tools, but as we've seen from the previous work, they all have similar efficacy at finding patients who are at risk of adverse outcomes. So the intervention was a multi-component interdisciplinary assessment. The fidelity of the study was by a performance that was decided by focus groups between geriatric medicine and emergency medicine clinicians, and a comprehensive multidisciplinary management plan was put in place. So the team was myself, under the guidance of the consultants in emergency medicine and geriatric medicine, physiotherapy, occupational therapy, social work, a candidate A&P in older persons care, a pharmacist, and the research nurse as well. So it was a big team, and I suppose all of the patients had different elements of this as part of their assessment. At the moment, the patient journey, when someone comes into the emergency department, you come in, you're triaged by a triage nurse, you're seen by the ED SHO, then you have your initial investigations and initial treatment. You either decided to go be discharged home, or you're admitted, you're deemed that you need admission. Then you're seen by a medical SHO, you have more investigations and treatment done. You're seen by the medical registrar if you're particularly sick. Then you're seen on the post-take ward round by the consultant, more investigations, more consults are seen. Then at that stage you might be referred to occupational therapy or physiotherapy or social work, and then you get your plan. So as everyone can see, this is a very laborious system. There's a lot of repeated assessments, and it can take a while to get through this system. So depending on how busy the emergency department is, it could take up to 24, 48 hours for all of this to be done. So what we did was we screened patients at the front door. They had their medicine reconciliation done at the front door, so they were all seen by a pharmacist. They had their investigations decided early on. They had multidisciplinary assessment from the moment that they came in. And if some of the patients had just come in with falls, they might have seen the physiotherapist before they even saw me. Specialty consultations and senior decision making was done at the front door. So the whole point of this was to make sure that there was a holistic assessment done without the need for the repeated assessments that are needed, that are done previous to this. So our intervention, I suppose, first of all, you have to deal with the presenting complaint. So whatever the patient came in with. And I suppose what we saw through the study is there's huge variability in this. So people came in with falls, people came in with chest pain, people came in with pneumonia, some people came in with medication side effects. So there's a huge variability about what people come in. And you have to deal with what they come into ED with. We looked at their comorbidities, we looked at their medications, and Stop Start was the tool that the pharmacist used for this. We assessed everyone for their falls risk, looked at their gait. We did a functional assessment looking at their sleep, their mood, their community support network, their environmental issues. Then we looked at the giants of frailty, so continence, bone health, cognition. And I suppose this assessment, it depended on what happened afterwards. So if it was a case that they needed admission, this flowed into the admission pathway. If they didn't require as much didn't require admission, some of this was followed up in the community, and some patients did, where we were able to assess all this on a once-off visit, and they didn't need further follow-up apart from their general practitioner. So it was a very patient bespoke model of care. So our outcome measures, the primary outcome was patient experience time in the ED or the AMAU, and these were the secondary outcomes that we looked at as well. So 228 patients were randomised, 113 into the intervention group and 115 into the control group. And I suppose the age was more kind of similar to what I see at the moment. So the mean age was 82.75. 40% of the total group lived alone. 55% came in by ambulance, and 42% had been seen by their GP. The Barthel index was lower in this group in comparison to the cohort study of 15.5. So the primary outcome in the CGA group, the time spent in ED was 11.5 hours, as opposed to the control group, which was 20 hours, and this was statistically significant. Looking at their index visit outcomes, we see the same here, but the hospital admission rate, so that's the conversion rate, was slightly higher in the control group. And patient satisfaction, the median one was much higher in the intervention group. Looking at the 30-day outcomes, there was no statistical significant difference in ED attendance, but there was a statistically significant difference in their Barthel index and their EQ5D, so that's a quality of life measure at 30 days. Looking at 180 days, the areas of statistical significance are in black. So there was a statistically significant improvement in ED attendance, hospital readmission, nursing home admission, Barthel index, so that's their looking at their function, and their EQ5D. At 6 months. So even though this was a once-off index assessment, the signposting and the management plans that were put in place did have an effect up to 6 months after the index visit. And this, looking at this is the quality of life measures and their Barthel over time. So the top line shows that with quality of life that improved in the intervention group over time, and with the functional Barthel assessments, the CGA group were stable over time, whereas the control group declined in their function over the 6 months. So I suppose it shows the importance that we know these patients who are screening positive for frailty are at risk of adverse outcomes, that we need to bring in frailty screening as part of the assessment of older adults. And a lot of the work I've been doing recently is looking at kind of triage modifications and stuff. The current way we triage older adults does not pick up the way that the adverse outcomes that they're at risk of. So it's really important that we look at expanding how we triage older adults. There's a need for bespoke patient-centred pathways, and the heterogeneity of what came in shows that we can't treat someone who has chest pain the same as someone who's pneumonia, the same as someone who's had a fall. And I suppose what we've shown through this work is the improved patient outcomes at 180 days. I suppose we had massive patient and public involvement, and it was a key underpinning of all of the studies, and all of the studies had an author that was from the ARC as well. So I think it's really important to hear the patient's voice in all of this, because we changed the outcomes of the cohort study based on the feedback from the older adult who was from ARC. So it does change the way we look at studies when we have PPI involvement. So I'd like to acknowledge everyone who was involved. This was a massive workload, and some of the people from the study are here as well, who've done a lot of work with this. So the emergency department in UHL, the geriatrics department, AMEU, the teams in the emergency department from a health and social care side of things, HRI, and obviously the University of Limerick, who've been absolutely excellent, and my two supervisors, Rose and Margaret O'Connor, who've been absolutely incredible the whole way through. So, any questions? Or we'll leave the questions to after. We'll leave the questions. Yeah, perfect. Thanks very much.
It's no surprise that Aoife has won Best Oral Presentation at several international conferences for her presentation on this phenomenal randomised control trial. Aoife, thank you so much. We're going to follow up now with a presentation from Professor Rose Galvin, and she's going to talk about the same study but focus on a process evaluation that was conducted on that study. Let me get the slides up for you there.
Perfect.
You all right?
Yeah.
So thanks to the HRI for the kind invite. And I want to say that I'm presenting these slides on behalf of Louise Barry, who is caught with exams this morning. So these will be a surprise to everyone today, these slides. But I also want to take this time to acknowledge that Louise Barry successfully defended her Viva earlier in the week on Monday. So just to congratulate her in her absence. And one element, actually all of her PhD work very much aligns with the work that Aoife Leahy has done. And as a testament to the calibre of the work that they have done, the findings of Aoife Leahy's trial, which is the first definitive randomised control trial that has examined this model of care in the emergency department, is under consideration in the Lancet Healthy Longevity. So this is really high calibre research, and as a further testament to Aoife's building capacity in this area, Professor Kenneth Rockwood, who derived this clinical frailty scale, is coming to UL to examine Aoife's thesis on the 27th of May. So this work is not only improving patient outcomes, but genuinely building capacity in UL. UL being acknowledged as a centre of excellence in terms of applied ageing research, particularly for older people who attend the emergency department. And one of the findings that Aoife presented was in this model of care that she examined in the emergency department, she reported at 30 days that the incidence of ED return among both of these groups was similar. So that this model of care, yes, while it was very effective in the emergency department in reducing, as Aoife calls, PET times that nobody else understands, but I understand as ED length of stay. So the length of time that somebody stays in the emergency department, but the correct name for it is a PET time. But we noticed that these people were returning to the emergency department at the same rate as if they had never received this intervention. And subsequent to this trial that Aoife ran, Aoife is now leading out on a team, one of these integrated care teams, which is all focused largely on admission avoidance. So trying to identify older people in the community who are at risk of going to hospital, so who are living with frailty, and Aoife is proactively intervening with them. And we have a further definitive randomised control trial ongoing that is looking at this more assertive approach to case management of this group. So that trial is ongoing and recruitment is really going according to plan. But back to the business of the day, which is looking at, I suppose, all of the factors that can't be explained quantitatively. So all of the factors that can't be counted as such that might have explained how this trial worked. So lots of the things that Aoife and the team did that supported the implementation of this trial in the emergency department. Because we should say that this is a very new model of care in the ED. To say that this is the first definitive trial that has been run internationally, it hasn't been examined because the ED is traditionally, a very busy environment, a single kind of condition environment, and it has been traditionally considered an environment where it's life or limb. So older adults presenting with complex conditions are a challenging cohort to deal with in the ED. So Louise Barry, as one part of her PhD, looked at, what were the factors that enabled the implementation of the trial and what were the factors that, maybe were barriers to scale up of this intervention nationally. And Louise achieved this through a number of different work packages. In the first instance, Louise did what we call a qualitative evidence synthesis, looking at the international evidence to show what are the barriers and facilitators to implementing screening tools in the emergency department internationally. And that was hugely important because the first component of delivering this model of care is identifying older adults who are most in need of this model of care. So identifying older adults who live with frailty. So Louise Barry did a qualitative evidence synthesis looking at stakeholders' reporting of barriers and facilitators to screening in the emergency department, and found that one of the most important barriers in terms of implementing a screening tool is having a pathway for people who screen positive. So, for example, I can implement a frailty screening tool, but if a person tests positive for frailty, what do I do with them? So this was the model of care that Aoife introduced that offered these clinicians a pathway. So that certainly was an enabling factor of introducing this frailty screening tool. But what I'm going to do today is describe and analyse the implementation processes that led to the successful delivery of the SOLAR trial, and look at fidelity, dose and reach. And these are common factors that are reported in process evaluation studies. So, as Aoife mentioned, Aoife's work was a complex intervention, and complex interventions are always underpinned by a framework to support their implementation. And we settled on this framework called the Medical Research Council's Framework for the Development and Evaluation of Complex Interventions. And there are lots of frameworks that exist to support the development and evaluation of complex interventions. And there's evidence to show that no one framework is better than the next framework to support this process. But the one we settled on was the Medical Research Council, so a UK-based framework that has been tried and tested. And this framework was updated in 2021 to, resolve some of the limitations that were reported in earlier versions. In particular, Aoife mentioned PPI involvement, so involvement of older adults from project conceptualisation to dissemination. And also, rather than looking at this as a linear model where you progress from one step to the next step to the next step, it's more iterative and cyclical. So you can always go back and remediate issues that you find as you progress. So we did a lot of work on developing the intervention, and obviously Aoife tested the feasibility of the intervention and then ran a definitive randomised control trial. But aligning to this MRC framework for the development and evaluation of complex interventions is an MRC framework for process evaluations, and they set out explicit criteria of what should be evaluated in parallel to the conduct of a randomised control trial. And that's essentially what Louise Barry looked at in this work. So the first thing that Louise looked at was whether the intervention was delivered as intended. And one of the issues with Comprehensive Geriatric Assessment, which is the model of care that Aoife described, is that it is a bit of a black box. So what exactly are people getting? Are they getting the interventions they should get? And what outcomes are being measured? So we've recently written an editorial on this, identifying, all of the issues around this model of care in terms of uncertainties. And one of the ways we addressed that uncertainty is we developed a 15-page proforma, a manual essentially for all clinicians who were involved in this trial. So all clinicians identified what assessments they were implementing, what interventions they were doing, what referrals they were doing, and these were all documented. So we could characterise exactly what this model of care was, rather than reporting it as something ambiguous and uncertain. However, one of the barriers, so one of the facilitators was that this was a collaborative team effort. So Aoife held a number of focus groups in advance of delivering this intervention to ensure that everyone was happy, to ensure that everyone was committed to this 15-page proforma. But one of the barriers to delivery of this was, of course, this trial happened during COVID. So that made the ED environment more challenging, more complex. And what Aoife has reported is that there were a sicker cohort of patients coming into the emergency department than would have traditionally come to the ED. But the team, one of the facilitators was that the team adapted to this model of care, and given that they had a proforma, that this was hugely supportive in developing and delivering the intervention. So one of the things we can do is characterise exactly what assessments people got, what interventions they got, what referrals they received, and whether those were followed up. In terms of dose often refers to the quantity of the intervention. So in the emergency department, it is quite a laborious process to implement this model of care. So for each older person who attends the ED, to deliver a comprehensive geriatric assessment is somewhere in the region of 4 to 5 hours. And I think, when I saw these figures coming in initially, it is quite surprising. But unless we get this message out there that actually older adult care in the ED or in the home environment is time consuming and it is costly, then there is no point in developing single disease or single system interventions to treat people with a myriad of conditions. So one of the barriers that this team identified was the amount of time. They didn't realise the amount of time that this would take. So in terms of building business cases for more support, more personnel, this certainly acted as a foundation to leverage additional resources for the team in the ED. And what we found as a facilitator was we know that this model of care confers benefits in terms of reducing ED waiting times. And I'm not sure if our colleague Niamh Cummins is in the audience, but I have heard Niamh present data whereby an older adult who waits longer than 6 hours in the emergency department is at increased risk of mortality. So these are frightening statistics when you think of people staying in the emergency department 24 hours, 36 hours, etc. So that in terms of the dose or the quantity of the intervention delivered, we settled that this was about 4 to 5 hours of an intervention that was delivered in the emergency department. So reach is whether the intended audience comes into contact with the intervention, and you can use both quantitative and qualitative metrics for this. So in our protocol, we normally accept around 20% of a dropout in a randomised control trial. But we had a dedicated research nurse who was so equipped and so established and so familiar with following older adults up in after an ED visit that we actually only reported a 6% attrition rate in the study, which is remarkable. What we also found in terms of external validity, and external validity refers to, well, how applicable would this trial be if I implemented it in another emergency department? And quite often what we see with randomised control trials is that their external validity or generalisability is quite low, meaning that by the time you apply all the inclusion criteria and the exclusion criteria, the proportion of people who come into the emergency department versus the number of people who get the intervention, there's quite a differential. So what we normally say about randomised control trials is that they're exploratory as opposed to pragmatic. But EFA's trial actually was a pragmatic randomised control trial because of all of the 260-something patients that were deemed eligible for the trial, only 40% or 40 of them, 40 of the 228 didn't meet the criteria for inclusion. So having a trial whereby over 80% of older people coming into the emergency department can benefit from this kind of a model of care is hugely impactful. So that's very different to exploratory trials where it could be 1 in 10, 1 in 20. And in terms of implementation, which is what Louise looked at, when you think about the consumers of this research, so clinicians who are reading this, they are much more likely to implement this model of care when they can say, well, this is a model of care that is relevant to 8 in 10 patients that I see in the ED. So that has been hugely important in terms of reach. So the other thing about reach is we didn't just quantify the reach of this intervention, but we also asked older adults, both in the intervention group and the control group, what they thought of this model of care, as well as the team themselves. So we interviewed 12, and when I say we, this is the royal we, this is Louise Barry interviewed. I was going to use a collective we. But Louise Barry interviewed 12 team members who took part in the SOLAR trial, and these were a range of different healthcare professionals, which is really, I suppose, reflective of the team. So no one individual or no one discipline had kind of, any hierarchy in that order of interviews. So interviews across medicine, allied health, nursing, etc. And so when she interviewed the SOLAR team, one of the things that they appreciated was that supported the implementation of this intervention is that they were involved from project conceptualisation right through to implementation, so that they were aware of all of the steps. And that is a testament to EFA, organising journal clubs, organising coffee mornings, organising breakfast events, so that the ED team and the geriatricians would come on board with this model of care. However, the elephant in the room, of course, is in the emergency department in UHL, there is a huge turnover of staff. So continually educating people on this model of care, trying to ensure that people were referred, were seen in a timely fashion was a huge challenge. And also because the team were consistent, the team that delivered the intervention, but it was linking out with others, that was just a challenging environment. But other things they found were having expertise in older adult care was hugely important and was a key facilitator. Clear leadership and clear governance structures in the emergency department. So EFA worked closely with the team in the emergency department in terms of the ED physicians, but also her own discipline in terms of geriatric medicine. And I suppose one of the motivators for staff is that they could see a more efficient and more effective model of care as they progressed through the trial. So that kept them motivated to participate. And the positive impact of interdisciplinary team working was hugely impactful too. In terms then of trial participants, so Louise interviewed both people who were part of the trial and people who were part of the usual care, as well as their family members. And one thing that struck me when she was presenting at her Viva on Monday was how she was so conflicted over people's reporting of being in the control group. You know, older adults said, oh, I signed up to this trial, but I really wanted to be in the intervention group. And then I was designated to the control group. And I could hugely see the value of somebody having responsibility for my overall package of care. And Louise found that very difficult because that's part of a randomised control trial, is reducing selection bias to ensure that the only thing that was different about these two groups was actually that one got this model of care and one didn't. And she found that hugely, conflicting for her as a healthcare professional. And that was also reflected in one of the key themes from this implementation, is that conducting research can be challenging, because older adults and family carers did report disappointment at not being involved when randomised to the control group. And we can see this playing out in lots of other interventions. And what sometimes happens in other interventions is that they go and try and receive the intervention elsewhere, which wasn't actually possible in this particular study. So people's experience of the trial, people talked about a preconceived notion of attending the emergency department in UHL, and that preconceived notion is played out in the media. It played out last week, it has played out time and time again. But actually, when older adults received this holistic model of care, they viewed it as being hugely positive, hugely empowering, and hugely supporting their discharge to the community or their inpatient stay. So certainly, once older adults can access this model of care, which we are, always advocating for, it has been a hugely positive experience for them. So I think it's really important to deliver that message also. And then challenges experienced in the control group are actually reflective of challenges that are present in the emergency department every day of the week in terms of older adults. It's a little more disjointed, more fragmented, and that appointments are challenging. Receiving information from different healthcare professionals can be challenging also. So really nothing different to what is routinely reported. So in terms of a final slide, what did older adults view of this model of care? They viewed it as organised and coordinated. And if I've read this once, I've read it lots of times from older adults. They want their care coordinated by one person. They want care that they can, if they have a problem, ring one person and they will coordinate whatever other activities they reach. And while that seems like a very pragmatic solution, that is actually not routinely implemented, not only in the ED and UHL, but in lots of EDs, both nationally and internationally. And older adults were eager to contribute to research, and that is certainly played out in terms of the low attrition rate, the low rates of decline. So lots of older people viewed this as a positive thing to contribute to future research. But we also see that played out more broadly in our PPI group of older adults and family carers. When I say we have sustained a relationship over the past 5 years with a group of older adults, I can tell you everything about their life story, but they have maintained a relationship with us, and they are so honest in terms of contributing to the types of work we do. So they really, like AoIFE has undersold how they have shaped the work that has gone into this solar trial, from how we identified the research question, how we implemented the study, how we delivered the information, and how we are now disseminating that information. So that PPI group of older adults and family carers, like when I say it underpins the work we do, it keeps the work we do grounded in what matters to older people, which is quite often to live in their own homes and in their own communities. So I'll leave you with that note. I should say we also quantitatively evaluated satisfaction, and you can see satisfaction levels out of a score of 5 on all these subdomains are much higher in the intervention group than in the control group. So this quantitative measure of patient satisfaction with their episode of care was much higher in the intervention group than the control group. So I'm going to finish on that note, and thank you very much. And thanks to Louise for allowing me to deliver these slides.
Fabulous. And Rose said to me when we were trying to decide who would present today, she said, Aoife Leahy will be the star of the show with the solar trial. And so a very hard act for our next colleague to follow for sure. We're changing tack and moving away from the emergency department-based research now to hear from our colleague, Professor Sarah Hayes, who's an associate professor in physiotherapy and is in the Ageing Research Centre, a real leader in stroke research with a very active programme of research. And she's going to talk to us today about some completed and ongoing work that she's involved in.
Excellent, thank you. Perfect, thank you, Katie. And yeah, it's definitely two hard acts to follow. I think I should have got in there early this morning. Anyway, so I'm going to talk to you for about 20 minutes just on some past research that we've done in terms of stroke recovery and stroke rehabilitation, and also just some current work that is underway at the moment. So I'll start by just giving you an idea, hopefully, of the burden of stroke and the consequences that somebody has after they've had a stroke. And then I'm going to talk about three pieces of research around stroke recovery. Firstly, it's around secondary analysis of a population-based cohort data set from the UK Biobank. And then I'm going to go on to the TAPAS trial, which is, we're coming to the end of it at the moment. It's the adaptive physical activity study for the secondary prevention of stroke. And lastly, then I'm going to present some work from a former UL structured PhD student, Mairead O'Donoghue, who did some really great work around the development of a complex intervention. We've heard around complex interventions and how they're developed in different frameworks. So she used a similar framework to intervene with people with cognitive impairment post-stroke. So it's all about stroke, and we're looking at different types of interventions that we have created and delivered. So as you can imagine, stroke is very heterogeneous. People can present with lots of different types of symptoms that can be very severe to mild, and with something like a clinical condition like that, there needs to be huge collaboration across disciplines. And indeed, I've been lucky to work with lots of different disciplines, from occupational therapy, speech and language, physiotherapy, doctors. UHL has been a brilliant clinical collaborator and partner. I really must say the work that's underway in UHL and stroke services is brilliant, and they've been such good research partners of ours. Worked very closely with Irish Heart Foundation. We've gotten great methodological support from centres such as the Trial Methodology Research Network, the Quest Network, both HRB funded, and across then the usual academic collaborations. But I suppose when I talk about teamwork and different disciplines and people working together to inform a research, I couldn't go any further without mentioning the huge involvement of our PPI panel. So public patient involvement, like Rose and Aoife were saying, that we've worked with those, a few key partners, people who've had a stroke over the last kind of 3 years or so, and they really have been involved with every step of all of the research that we're doing, from conceptualisation down to dissemination. So these are some photos. I scrolled through my phone just to try and find a few photos. People never stand for a picture, really, do they? But this is from our last September. We held our first, hopefully not the last, stroke research afternoon that we held in Circ in UHL. So it was really well attended. It was a brilliant afternoon, and it was actually opened by two of our PPI panel members who have had a stroke, Mike Butler and Jim Bradley, and they were delighted to do that, tell their story, and give their experience of being co-researchers with us, I guess, here in UL. So stroke is a big problem. It causes lots of difficulties. It carries with it a lot of burden. It's the second leading cause of death, third leading cause of disability worldwide. So it is an issue that certainly needs to be tackled. We need to help people to live better with it, and even if we can prevent them having it in the first place, all the better. Over 6 million deaths, 143 million disability-adjusted life years globally. In Ireland, then, more locally, about 10,000 people have a stroke every year, and about 30,000 people who are living with the residual consequences. Physical, so things like motor weakness, pain, spasticity; cognitive, so difficulties with memory, attention; psychological, so mood, anxiety; social and financial consequences. So it's something that affects everybody differently, and for sure can affect people in lots of different ways. So when we're grounding our research and trying to think of what's the most important questions, I suppose, to tackle within the research group, we often look to the James Linden Alliance, which is a priority setting partnership in the UK, wherein 10 basically research priorities are put together by people with stroke, healthcare professionals, carers, so people that the research affects directly. And I've picked 3 here that I'm going to talk about in the next few slides around exercise interventions. We need to know more about that and how it can prevent further stroke. Primary prevention, so stop the first stroke, and then issues around secondary prevention and preventing a recurrent stroke for people. So they're key priorities that underpin our research. So primary stroke risk, or one's first stroke, it is preventable. 91% of the incidence is attributable to factors such as smoking, poor diet, and low physical activity. And low physical activity actually makes the second largest contribution to stroke incidence. So something as simple as being physically active is one of the key things you can do to stop having a first stroke. Many associations between many risk factors and stroke incidence, however, have not been, identified with much accuracy in a working age population. So people 40s, 50s, 60s, 70s. And actually the data is demonstrating, international data is demonstrating that people are having strokes at younger ages and more minor strokes. So I suppose there is a shift in the type of person that is presenting with stroke clinically. And of course, primary prevention measures are critical. So this led us on to examine the association between self-reported walking pace and incident stroke. We used the UK Biobank data, so we collaborated with a group of researchers in Glasgow. This was published in 2020 now, in stroke, and there was over 500,000 people enrolled between 2007 and 2010 and then followed up at intervals. We did landmark analysis, excluding any events occurring in the first 2 years of follow-up, and we conducted Cox proportion hazard models. A great thing with Biobank is that there are just a huge amount of variables that we could choose from that are very relevant and I suppose evidence-based in terms of our choice of those variables to confound for in the analysis. So everything, all the socio-demographics, health factors, diabetes, hypertension, blood pressure, literally anything and everything has been captured by this data set. And results briefly demonstrated that compared to an average walking pace, if you walked slower, so less than 3 miles per hour, you had a 45% more chance of risk of incident stroke, fatal or non-fatal. So that was, I suppose, quite an obvious, or I suppose not an obvious, but it was quite a startling result really in terms of the risk and how that is heightened with a slower walking pace. Something that is very easily to be measured essentially clinically. We looked a little bit, I suppose briefly, we looked a little bit more closely than at other aspects of physical attributes such as muscle strength, fat-free mass. We used the same analysis method, Cox proportion hazard measures, and again we found that the risk of incident stroke was inversely related to muscle strength, so higher muscle strength, reduced risk of stroke, both stroke incidence and stroke mortality in the finally adjusted models. And also this was demonstrated between the association with fat-free mass, or so kind of about lean body mass, and stroke incidence and stroke mortality. So they present as walking pace, muscle strength, fat-free mass. They're quite cheaply used measures that somebody in primary care or GP could collect and identify potentially people who are at a higher risk in that working age group. So people kind of between 40 and 70, and that they may benefit from further assessment of risk factors. And indeed, primary prevention strategies can use some of this information. Moving then on to, unfortunately, if somebody has an initial stroke or a primary stroke, one's risk of having a repeated or a recurrent stroke is much higher. So the repeated risk is at 1 in 5 years is 11 to 26%. There are a plethora of international guidelines around the prevention of secondary stroke, and they recommend targeting things like lifestyle factors, blood pressure, levels of fat, obesity, etc. And unfortunately, even though we know how somebody should, what they should avoid, and lifestyle and other factors that one should target post-stroke, they remain poorly controlled among stroke survivors. Physical activity interventions, and again, I'm from a physiotherapy background, coming to this from that perspective, does present as one of the cornerstones of secondary prevention post-stroke. And indeed, because stroke is so different from different people, personalised individual interventions that do tackle an individual's response to rehab certainly is recommended by one of the clinical guidelines. So this brings us on to the current TAPAS trial, which is HRB funded, due to end in July 2025, wherein we are using a sequential multiple assignment randomised trial, or a SMART, to develop an adaptive intervention to tackle physical activity in order to prevent secondary stroke using mobile health, or basically smartphones. Now, the pictures here on the slide are of people who are doing all the hard work on the ground, so they can interrupt if I say anything that's incorrect. But so we have Dr. Aoife Whiston, who was a postdoctoral researcher on the trial, and Aoife has moved on to her tenure track position in psychology. The last on the right then is Pádraig Crowcliffe, who's the current postdoc, collecting a lot of the follow-up data. And then we have Amy O'Mahony and Siobhan O'Reilly, who have done great work, again, as blinded assessors on the trial. So again, all of the hard work has been done, certainly on the ground. So in order to design this intervention, we did some qualitative work at the start. And we interviewed 28 people with stroke, carers, healthcare professionals. And some of the key themes that came out of the findings, excuse me, just have to take a bit of water, are around, are around the key features of the mHealth intervention, who needs to deliver it, how it needs to be delivered, where, and then challenges. So certainly there were challenges. People thought of mobile health, smartphone, how is this going to work with a stroke population? There's already so vulnerable, there's lots of things going on, but we really gleaned some very useful information that we used going forward. So the TAPAS trial is underway, as I said. We've just finished recruitment, and we recruited through UHL and our Irish Heart Foundation, as well as Camillus and St. Ita's. We looked at people who are living in the community post-formal rehabilitation. And we collected baseline, post-intervention and 3-month follow-up outcomes. The primary outcome that we're interested really is around feasibility, and also secondary outcomes such as mean steps per day, sedentary behaviour, etc. So the protocol is published and the trial is registered. So in terms then of the intervention, so this took a good year to develop. It was very firmly grounded in behaviour change theory. Also in terms of our own Cochrane review informed the content of the exercise intervention. And we went to external collaborators, an external company, to develop an app. So that took a year and a half and a lot of work, and I certainly was outside of my own comfort zone. So we developed an app, again, huge contribution from the PPI panel, and it's synced with a Fitbit. So that meant that we were able to deliver that personalised, individualised intervention to each individual who took part in a trial. So it's slightly different. So you've just been looking at the SOLAR trial and randomised control trial, and that's what you typically expect in terms of vanilla standard trial. This is slightly different in terms of methods. I hope it's not too complex. Come back to me when we've all the analysis done. But essentially, people are either randomised to an exercise group or a lifestyle physical activity group at the start, and they go through a 6-week intervention. And I can talk to that again. But they're deemed either a responder or not a responder. So I suppose it's kind of mirrors clinical practice. If something is going well, they're a responder to the intervention. It's based on steps and how well their exercise is progressing, their targets. They continue in that group. However, if they're deemed non-responder, which we use a tailoring variable to consider, they are re-randomised at that stage to either basically you kind of switch the intervention or you step up the intervention. So there's 2 randomisations basically for lots of the people throughout. Some people might be just randomised once and they continue as they would in normal clinical practice. So it means that we're looking at a slightly different, I suppose, research question than a normal trial. this trial design is used to develop an adaptive intervention, something that adapts. And the primary aim of ours is to determine which of the embedded adaptive interventions leads to the greatest improvement in physical activity. So I suppose it kind of mirrors the practice in that not everybody responds to the intervention that they're given, and this allows the empirical examination of that. Hopefully it does. Okay, so in terms of, I suppose, impact, we gave a webinar last September, myself, Cathal Walsh and Professor Kelly Goodwell, who is, I suppose, a main international author in the SMART methodology through the Trial Methodology Research Network. It was attended by, I think, almost 100 people, and it went very well. But this method hasn't been used in Ireland. It hasn't been used in stroke rehab. I think it does. It certainly does appeal to me in terms of, the personalised interventions. But yeah, a lot to report in the coming months. Now, so Cathal has warned me we're not actually allowed, of course, divulge much of the results. So some preliminary analysis that I can give you. We enrolled about 54 people, and 2 have just dropped out by the end of intervention. So it's going very well in terms of attrition. The cumulative recruitment then, so we planned on 5 people a month over 10 months, but we actually got to that within 5 months. So that went a lot quicker than usual, and I'm not used to presenting recruitment rates that are quicker than presented. So I don't know if it was just pot luck or brilliant postdoctoral researchers or assistants, but it went very well. Now, we did note that it was tapering off then as we got to the 4th and 5th month, so we were happy to just count our chickens and move on. In terms of baseline descriptives, just to give you an idea of the type of people who took part. So as you'd expect, I suppose there was a requirement for the ability to use technology, have a smartphone, internet connection. So the majority of the mean age was about 51, which is slightly lower than usual stroke trials. The majority of people were either working or unable to work. And then in terms of clinical variables, so some of these might not make a lot of sense to many of you, but basically they were a fit enough population, so they were able to take about 7,000 steps at baseline per day, which is more than I take some days. But there was a large range, so we included people with a modified Rankin scale of 0 to 3, which is people who were able to walk unassisted. But there's a big discrepancy. There's a big variation there in terms of disability. People were reporting fatigue, substantial fatigue, quite good in terms of quality of life. They would have been above the cutoff in terms of anxiety and depression, so demonstrating that. Quite good reintegration into normal life, quite good EQ5D scores in terms of self-reported health rating, and they were actually quite sedentary, even though they had also taken quite a good few steps at a mean. So their weekday and their weekend sedentary behaviour was about 7-8 hours and 6 hours. So that's the kind of a clinical picture of the population. And hopefully I'll be able to give the full results around September, October 2024. So I suppose in summary then, this TAPAS, we're using a novel experimental study, a design that is aimed to develop an adaptive intervention. Then this adaptive intervention will be used and compared against a normal treatment as usual group in a further trial, randomised control trial. We've also simultaneous process evaluation ongoing and economic evaluation. So I think we've 25 interviews done for the process evaluation. So that's all going fine. And then luckily, actually, we were awarded. We were picked as one of the 10 projects nationally for a Sphere PhD funding that's due to start in September. And again, it's kind of building on the work of this TAPAS trial. So moving back then, looking at another key, I suppose, priority for stroke rehabilitation research brings us to cognitive impairment. And a brilliant PhD student, Mairead O'Donoghue, who is now in UCD as a postdoc. We tried to keep her here, but she wants to move to the big smoke, essentially. So Mairead has done great work in this, in developing a cognitive impairment intervention and testing it. So cognitive impairment, anything from memory, attention, executive function, language. So it's an umbrella term for lots of different difficulties that, as you can imagine, do have a huge consequence for people's lives. We know that a pooled prevalence in terms of meta-analytic findings, around 38% of people 1 year post-stroke still present with cognitive impairment. So it is something that certainly does present as a research imperative. It has been under-examined compared to other medical physical issues, for sure, in the stroke world. So Mairead published, and I should say actually, so Pauline Boland is in the audience as well here, and Rose Galvin were the co-supervisors on this piece of work. So Mairead published a very in-depth systematic review meta-analysis in stroke with over 4,000 participants, 64 studies, wherein she looked at different types of interventions to address cognitive impairment after stroke compared with treatment as usual. And essentially, this was quite new actually in this sphere, because usually interventions are looking at one aspect of cognition only and one kind of aspect of measurement only. So this was quite new, and it was received very well by reviewers. And our key findings were that a multiple component intervention, including kind of occupational therapy and physical activity interventions, did demonstrate significant favoured the intervention for cognitive impairment and other secondary outcomes. So it's one thing having some quantitative evidence, but we needed more work around, from qualitative stakeholder perspectives in terms of people with stroke, carers, healthcare professionals, and Mairead interviewed 30 people around what do we need to do to design an intervention to address cognitive impairment. There just isn't that information there in the existing evidence base. And so some key themes emerged from the data around the intervention needs to be meaningful and needs to take into account people's own interests and preferences. The point of readiness was a key thing. So most of the healthcare professionals and indeed the carers felt that straight away, as soon as possible, even in ICU, start straight with cognitive impairment rehabilitation, whereas some of the people with stroke certainly felt that there was a period of adjustment and coping needed after having a stroke and coming to terms with a lot of it. So there was some key findings there in terms of when actually to intervene. A familiar, flexible environment, so I suppose similar to some previously mentioned, home is often the preference, of course it is, and having that, even if it's not possible, home, having a familiar environment for somebody, as you can imagine, with a cognitive impairment is crucially important. And then key things around the pragmatics of intervention development. So we use the tidier framework to structure the interview schedule. So, who is involved, OT, physio, etc. Where would it be? How long would the intervention take, etc. What would be too much maybe to do? Should it be done, in 10-minute slots over a week, or, once a week in a 2-hour session, etc. So again, some key take-home messages, and we really used an awful lot of those in terms of intervention development. I'm skipping quite quickly now through some of this, but Mairead then did a feasibility study, a very small feasibility. And again, you can imagine this is the first feasibility study looking at a multiple component intervention for cognitive impairment after stroke. It was done during COVID, so it was the middle, I don't know which lockdown it was, but nobody could go anywhere essentially, so it had to be done online in order to finish the PhD. And indeed, I think that is something that potentially is a barrier. We recruited through UHL and the Irish Heart Foundation, and again, people who had a confirmed stroke and mild to moderate cognitive impairment. So key things we were looking at really is it safe? Is it acceptable? Is it something that people will be satisfied with? So very much a feasibility piece of work. And then some key secondary outcomes around clinical variables. So a 6-week cognitive rehabilitation and physical activity intervention was delivered by an OT and a physiotherapist. And around feasibility, so recruitment rate was 7%. So it took 4 months to get 9 people. So there's a key finding there in terms of point of readiness. So these were people leaving UHL. The online component, I think certainly a process evaluation would bring out some difficulties there. But retention, once people came onto the trial, was very high. Adherence was good to excellent. There were no adverse events, and people did find it acceptable. But there is something certainly there around recruitment that needs to be taken into account in the next phase of the work. Now, some of these won't mean an awful lot to many of you, or some of you, but looking at, there was only 9 people that we recruited in this pre-post intervention work, and there were large clinical improvements really in all of the measures of cognitive function, fatigue, quality of life, and goal attainment. So it's something certainly that provides key data going forward. In terms of impact then from her PhD work, Mairead has been invited to join the next joint guidelines on post-stroke cognitive impairment by the European Stroke Organisation and European Academy of Neurology. which is a big feat for Mairead. Our meta-analysis has been, I suppose, widely published in clinical guidelines. Particularly, the most recent is the Canadian Stroke Best Practices. And building on this work, then again, we hope to find out in the coming month or so if we've been successful in... Oh, actually, no, that's not this one. Sorry, we've already gotten this. Yeah, sorry. This is, we have been successful in, it's a different study, in acquiring from the HRI, and we're so thankful and grateful for this, a core outcome set. Again, so it's building from the meta-analysis wherein we notice big heterogeneity and difficulty in measurement of cognition after stroke. So again, this is a PhD starting in September. So that's fantastic to have that. So to conclude, stroke brings considerable burden. We know from population-based data that there are associations between lots of different things that could be easily measured, such as self-reported walking and other physical measures, and primary stroke. We hope that adaptive interventions, things that do respond to individual preference, show promise for the development of personalised interventions. And we have a multiple component cognitive impairment intervention that does seem feasible and acceptable, and certainly would be important to do further work in this area. So thank you very much for your time.
Wow, Sarah, you definitely weren't a second act at all. That was just so impressive, phenomenal work, and I think just, listening to all three speakers, just methodologically excellent work, interdisciplinary work that's really enriched by having many perspectives, and just a really strong thread of PPI involvement throughout. And we should say that none of that would have been possible without the funding that we were awarded through the HRI, which allowed us to get our PPI panel off the ground and recruit people like Dr. Aoife Whiston, who's now leaving the room, as a postdoctoral researcher who was involved in pretty much all of the research that was presented today. So we have a few minutes if anyone has questions for any of the presenters. I can, of course, generate some questions if needed to put them on the spot, but any reflections or comments from anyone in the audience, more than welcome. Yes, Helen.
Sarah, really interesting, Sarah, to hear the various strands of your stroke research. With the cognitive intervention, were those stroke patients, did they have cognitive impairment before they had the stroke, or was it cognitive impairment from the stroke?
Yeah, so I think this works. Yeah, it does. Thanks, Helen. So they didn't have cognitive impairment pre-stroke, so it was post-stroke cognitive impairment, and it was mild to moderate cognitive impairment. Yeah, so we used the Addenbrook's scale to use that as a cut-off of 88 out of 100. So yeah, often I suppose you've picked up on something that is comes up a lot in terms of cognitive impairment, especially after an event such as stroke. How much of that was pre-stroke. So it would have been noted in terms of the inclusion criteria that there was no diagnosed cognitive impairment post-stroke. But I suppose, as you know, that often people may present with a stroke, and obviously it's hard to measure pre-stroke cognitive impairment. So it would have been from family members saying there was no cognitive impairment. So it's self-report, and it's based on, I suppose, a proxy report. But yeah, thanks, Ellen.
Sarah, you gave me the fear with the walking speed findings, because there's a colleague in the audience that I've been on a few walks with, and she said to me that I am the slowest person she has ever walked with. So
I'm not far behind him. I'm a very fast runner, but slow walker.
Okay, so something to address for sure. Any other questions for any of the group? Thanks, Helen.
Thanks for fantastic presentations, and I love how much international reach you have. It's really putting UL on the map, the ARC on the map. I think that's fantastic. I couldn't resist asking Sarah a question, because you're doing physical activity work, and I'd have a lot of questions, but I'll
we're all friends.
I'll have to kind of focus just on one point, and it's an issue for us as well, in that when you work in physical activity, it's very hard to recruit inactive people. And that's as true in the general population as it is in clinical populations. And I kind of noted your 7,000 steps a day at baseline in your clinical population is probably well above the average for that age range. Have you any thoughts on that and how, you might, is there any way of targeting more inactive people?
Yeah, so absolutely. And I suppose when we look at the results in more detail, we'll be able to tell, the proportion of, where like I can remember one person who came in and his average steps were 30,000 steps at baseline. So he's going to be a problem for a group of 50. So it will obviously bring up the average. So in terms of the proportion of people and how many people are at that level, I'll be able to report in detail later. But I take your point in general. The mean across the group, 7,000 steps, yeah, it is very high. So like in terms of, you'd be looking for 6,500 to 8,000 steps a day would be a target actually for a chronic disease population such as stroke. So we did get a fit sample. Any ways of targeting people who are, we could alter the inclusion criteria, the section criteria, and I've done that actually previous in a multiple sclerosis randomised controlled trial wherein we looked to bring people who are physically inactive, not taking steps, not active, and bringing them to meet the clinical guidelines. But I suppose this is something that we want. There are so many different novelties with this study in general in terms of even using I can't describe the anxiety I had in terms of downloading an app onto somebody's phone, giving them Fitbit, pairing it, having them interact with a virtual 12-week intervention using this technology. So, in order to get it up and running and see how it was going, we didn't restrict inclusion to a more inactive population. But look, this is, I suppose, the tip of the iceberg really in terms of using technology in a stroke population, and it's something we certainly will be considering in future research. Yeah.
No, thanks. And, I don't think there's a straight answer to how do you access those people. We had a recent study in Limerick City in older adults where we actually used WHO guidelines. So you had to not meet WHO physical activity guidelines to be in the study. And one of our participants then in his baseline did 850 minutes of MVPA in the first week.
Okay.
And that's not normal. That's way off the scale.
Yeah.
So it's really hard to filter. But I think, there's definitely something when you're recruiting for a study with an exercise component, you get people who are, contemplators and beyond. They're definitely interested in physical activity. And I don't think anyone really has reached a way of reaching out to the people who really need it, the ones with the 2,000 or 3,000 steps a day.
Absolutely. And look, there are people, a lot of people in the group actually went from, those people who were 700 steps and they gained, 100 steps a week, and that was huge for them. So for sure, but in terms of reaching, I suppose, that type of population, our PPI panel is something that we find very useful, and we will going forward. So coming up with ideas how to attract and to bring in that subset of the population is important. We were very surprised. We did not think this is not usual. So it's a finding in itself for sure. Yeah.
Thanks.
Thanks, Ellen.
We probably have time for one other question. If no one has one in the audience, Aoife, can I ask you about... Oh, sorry, somebody does. Apologies. Abdi.
Two quick questions for Dr. Leahy. Thank you for your excellent presentation as usual. And as you said, the aging population is growing and the prevalence of frailty is also increasing. And there are big debates about, what's the best screening tool to use and what's the best diagnostic accuracy for frailty. So I'm wondering, from your studies, what is the best screening tool that you come across? And my second question is, what struck me about the findings about the 6-month follow-up is the big difference between the intervention and the control group in terms of the adverse outcomes such as, representation and nursing home admission. And I'm wondering what accounts for that. Is that because of the lack of proper care or follow-up for these patients in the community after their index visit to the hospital?
Really good question. There's actually a paper in the Age and Aging this week about frailty screening, consensus work done by Liz Maloney down in Cork, so it's similar work to what we've done as well. I suppose I think at the moment we're putting so much effort into finding the perfect frailty screening tool. And I was at EU GMS during last summer, and it was the same thing. Finding another screening tool, and upon another screening tool. I think if we just screen with something that's feasible, that people will use, that we can find these patients, find the ones that are at risk of adverse outcomes, I think that's where the money is. Like, when is in some of the work that I've done, like there's 80 different surrogate markers for frailty that have been used in different studies. We don't need to be looking for more frailty screening tools. In the cohort study, it was fairly similar across the board that these the 4 screening tools that we used had similar efficacy at predicting adverse outcomes. So I think it's whatever you can use in your different settings. And I think nationally, from a clinical guideline point of view, it's the clinical frailty scale, which is used in most units, and that's what we're using in ICPOP to identify patients that come into our service. So ICPOP is integrated care. That's the community hub that I run. So I think whatever you can use, I think, and as feasible in settings. I'm involved in the national guidelines for frailty at the front door as well, and I suppose a lot of the work we're doing at the moment is to look at frailty screening in the post-triage space to try and make it more adaptable and more feasible in the emergency department as well. So that's that side of things. And your second question, the difference between the intervention control group. I've spent a lot of time thinking about this, and I think looking at Louise's process evaluation kind of gives more in-depth knowledge in what was happening in the control group. A lot of people in the control group they came out of ED, they weren't sure what happened to them, they weren't signposted to different services, they felt that their needs weren't being met, whereas in the intervention group, they had so much information leaving the emergency department. They knew the services that they would be able to get in the future. They were able to link in with a public health nurse, with GP. Some of the patients I followed up in virtual clinics, and they were linked into different outpatient services and things like that. So I think that's where, and having that information and them having the agency to know, look, the issue is my incontinence, I need to meet with my public health nurse, and she'll be able to look at those issues in the future. And that was across the board for different areas. So I think that was a big reason that people did well at 6 months. Yeah.
Great, thanks. Aoife, I wonder, while you have the microphone in your hand, in terms of scale up of the solar intervention, is it happening nationally, internationally? What next?
So I'm co-chair of the national guidelines for frailty at the front door. So we've a clinical advisory group that's a collaboration between the emergency medicine programme and the national clinical programme for older persons. So we're looking at it at the moment. The difficulty is the heterogeneity between the cohort of staff in different frailty at the front door services. So we're looking at the guidelines at the moment, but it's very difficult to say bring in very close key performance indicators for frailty at the front door services when some of the frailty at the front door services are just one nurse on her own, or his or her, whatever. So it can be very difficult. And then in some other institutions like the Mater have a very robust frailty at the front door service. Cork and different units have different services, so it can be difficult with the heterogeneity across the board. But I think bringing in the frailty screening tools, bringing in delirium screening is a start, and then we can build in the future as they go on. But I suppose it's trying to get the staff in place at the moment, which can be very difficult.
Yeah, absolutely, for sure. I think on that note, we are just exactly at 10:30, I think. And can I finish just by saying thank you so much to our 3 speakers. Look, I thought you were just absolutely so fascinating, interesting to listen to, brilliant presentations. And the impact and the translational element of the work that you are doing is just so clear, and how it responds to patient priorities and preferences. So it's a pleasure, as always, to hear you and to collaborate with you. And congratulations, and thank you so much for your presentations.